Good evening, everyone. Thank you for attending our first ever Wellness RX lecture series. First, before anything, I want to start by thanking the team of Surge Kuwait, who have been very vital in making this happen. I approached the team a couple months back about this idea, and from the beginning, they were super helpful and very excited to offer this to us here. Hello, sorry about all the technical difficulties. Sorry, I'm back. I just want to say sorry about all that. I wanted to introduce Dr. Carol Garber, who's with us. He is the Professor of Movement Science and Education from Biobehavioral Sciences at Teachers College. He's also the Director of the Graduate Program in Applied Physiology, as well as the Director of Exertion Clinic for Exercise Testing and Prescription. Carol is also an clinical exercise physiologist who looks at the benefits of exercise in the prevention and treatment of chronic diseases and chronic conditions across the lifespan. Sports Medicine chapter, as well as the American College of Sports Medicine, and is the recipient of the 2019 Citation Award from ACSM. She's been the author of 130 published articles and book chapters, including lead author on the seminal American College of Sports Medicine position stand. So I'd like to hand over to Dr. Carol Garber to take over.
Good evening, everyone. Thank you so much, Osama, for that kind introduction, and thank you so much for inviting me to join you today and at the start of this wonderful wellness series that you've planned. The topic of my talk today is movement is medicine. And first, I did want to let you know that I do not have any conflicts of interest. And I'd like to greet you from the Exertion Clinic. So these are some photos of our clinic in New York City, where we, pre-COVID at least, were able to see clients and patients and evaluate their exercise capacity and health parameters, and to provide counseling for a wide array of people, from elite athletes to very deconditioned individuals. And we also do work within our community, helping to inform people more about why exercise is good for their health. Today in my lecture, I'll be talking about three major areas. First, I'm going to talk to you about why exercise is important. Next, I'll talk about how much exercise is needed. And finally, discuss how you can incorporate physical activity into patient care. So, as early as in the 5th century BCE, Hippocrates recognized the importance of physical activity for health. He said, walking is man's best medicine. He also recognized the importance of healthy eating. And he said, if we could give every individual the right amount of nourishment and exercise, not too little, not too much, we had found the safest way to health. And these words ring true today. And more recently, Robert Butler, who's the founding director of the National Institutes on Aging here in the US, said if exercise could be packaged into a pill, it would be the single most widely prescribed and beneficial medicine in the nation. Little did he know that the research in this area would grow so exponentially, and our evidence would become so strong to support his statement. The result of this widely researched area are many scientific evidence-based guidelines, which a few of these I show here. So ranging from the UK to the US, the Canadians, the Australians, and many, many other countries have used this scientific evidence to develop exercise and movement prescription guidelines. So these are some of the few benefits of exercise based on our scientific evidence. Enhanced cardiometabolic health, weight management, improved physical function, lower risk of falls and fall-related injury in older adults, better quality of life. In addition, lower risk of all-cause and disease-specific mortality for heart disease, heart failure, stroke, and some cancers, and lower risk of disease-specific morbidities, and improve brain health, so enhanced cognition, including enhanced attention, executive function, improve symptoms or reduce symptoms of depression and anxiety, and enhance sleep, so better sleep efficiency, sleep quality, and a decrease in sleep during the daytime. Here I show the relationship between overall physical activity and all-cause mortality. And you can see here that with very little activity, we're starting here at almost no activity as we go along the x-axis, or increasing amounts of overall physical activity each day. And you can see that there's a curvilinear relationship, so that with increasing amounts of physical activity, there's quite an exponential decrease in all-cause mortality risk, which means that you don't need to do very much activity in order to gain some of these health benefits of physical activity. We know now that higher levels of any intensity physical activity, so ranging from just moving about at very easy pace, not an exercise, just as part of your daily activity, to more intense exercise, all demonstrate a dose-response relationship with all-cause mortality. So here in the top are similar to what I just showed you with all physical activity. And in recent years, there's been a lot of attention to light physical activity. So this is activity that feels pretty easy, doesn't really get your heart rate going up. And we can see no matter how much light activity you have, you can see here we have this dose response. Here's even very low levels of light physical activity, that as you do more of it per day, your risk of all-cause mortality decreases. As people do a little bit more light activity, and you can see that the benefits increase. And it's even better if you're able to engage in more moderate physical activity. So this is activity such as a brisk walk, or more vigorous activity such as a run. But on the other side, we know that being more sedentary or inactive has an inverse association, so that the more time you spend in sedentary activity results in a much higher risk of all-cause mortality. And I'll direct you to the bottom right of the screen. So you can see here the number of hours per day of sedentary activity, so includes sitting and the like, sitting at your computer. And you can see that with increasing amounts of time per day of sitting, that the risk of all-cause mortality increases in a curvilinear manner. So this is a concern and has become a focus of many of the physical activity guidelines. For example, the Canadians just released 24-hour physical activity guidelines to address some of these issues of sedentary behavior, and also the relationship between lack of sleep and physical activity. However, if you exercise regularly, you're not fully off the hook in terms of potentially having an increased risk of mortality. So this slide shows over on the left-hand side, this is the relationship between sedentary time and at various levels of physical activity. So these are the hours of sitting per day on the x-axis and the hazard ratio on the y-axis. And these lines are showing different levels of total physical activity, with the most active people here and the least active people on these top two lines. And what you can see is for those individuals who are less active, that even though they do get some physical activity per week, it isn't enough to fully attenuate that increased risk. Similarly, we see over here similar relationships with cardiovascular disease mortality. This has led many experts to suggest that we might want to break up our physical inactivity or sedentary time throughout the day as a way to address this problem of sedentary behavior. We don't have enough evidence currently to be able to say exactly how often you should break up the physical activity or what types of movement that break should consist of. There is some evidence, however, that breaking up sedentary time over the course of the day, so getting up from your computer for a few minutes every hour or so, is probably a good strategy. But in the future, we will be able to give more direction to individuals on how to address this additional health risk. So back to physical activity. I showed you that physical activity, or the lack thereof, is associated with an increased risk of all-cause mortality. Similarly, many of the disease-specific causes of death are also been shown to be associated with physical activity or lack thereof. And this is shown here in this slide. We can see here on the top, we have breast cancer, colon cancer relationship here, diabetes risk, and then finally we can see ischemic stroke and ischemic heart disease. So you can see that these relationships with disease-specific mortality are similar, and the diseases shown here are those that we have the most evidence for. It doesn't mean that other diseases are not affected by physical activity, just that we have not accumulated sufficient evidence to answer some of those questions. You might have heard that exercise could be dangerous and that the people may have an increased risk of having sudden cardiac death or myocardial infarction during exercise. And that is, in fact, a fact, that one's risk of having an acute coronary event is transiently increased during physical activity. But I want to tell you something, which is that with increasing regular physical activity, that transient risk is decreased. So here you can see this is an individual who doesn't exercise at all. And this will be our reference person. So the risk for that person of unexpected movement is fairly high, although it's still an uncommon event, but catastrophic if it happens. But here, look what happens as you increase the number of days per week of getting some vigorous physical activity, that it's a linear decrease, so that for those people who get at least 5 days per week of vigorous activity have about 50% lower risk of experiencing an acute coronary event during exercise compared to that person who doesn't exercise at all. And further, you can see these here. I wanted to show specifically, here is the association with number of days of physical activity and risk of myocardial infarction. And here we can see that association with sudden cardiac death. So for those who exercise the most, their risk of experiencing acute MI is about 47% reduced and about 30% reduced risk of sudden death. So exercise is slightly risky, still a rare event to have these catastrophic events. However, exercising regularly attenuates this risk substantially. So I wanted to move on to talk about some of the benefits for other types of chronic diseases. So the evidence has been growing exponentially in terms of the association between physical activity and the risk of developing cancer. The most recent U.S. Physical Activity Advisory Committee report summarized these existing studies at this time and have found that there is strong evidence, good quality evidence for relative risk reduction of developing cancer, at least in some types of cancer, as shown here in the red box. And these risk reductions range from about 12% for renal cancer to about 25%, possibly in lung cancer. So this is really another important benefit of moving regularly. In addition, for those who have cancer and are cancer survivors, regular physical activity is associated with a risk reduction that can be as much as 48 or 49%, depending on the type of cancer, with all-cause mortality as shown here. And with disease-specific cancer mortality, risk reduction of cancer-related deaths about 38%. So that's pretty powerful effect of physical activity. Further, it's been shown in many studies that exercising after a cancer diagnosis has an effect on not only the efficacy of many of the treatments, but the effect on cancer recurrence as well as cancer progression. So this recent meta-analysis suggested that there may be any range from 56 to 75% of reduction in recurrence of cancer and progression in some well-designed prospective studies. And further, there's increasing evidence in mainly animal models that exercise that is added to a treatment regimen can actually affect cancer tumor growth through a number of different mechanisms. These are mainly in animal models currently, but it goes along with some of the findings that have been noted in human studies. So if I haven't given you enough reasons to exercise, exercise or activity, it doesn't have to be exercise, just moving around will do the job. You'll have a reduced risk of developing high blood pressure with increasing numbers of exercise hours or activity hours per week. So a nice linear association between regular physical activity and the development of hypertension. And, if you've already have hypertension, becoming more active can reduce your blood pressure. You can see here in systolic blood pressure, if your hypertension on average, just adding aerobic exercise can result in a reduction of systolic blood pressure of about 8 millimeters of mercury and about 5 millimeters of mercury in diastolic blood pressure. And you can see also in prehypertension, we also have beneficial effects seen in multiple studies. Well, what about diabetes? We know that physical activity is recommended as a part of treatment for type 2 diabetes. But can physical activity potentially prevent diabetes from occurring in individuals? And the answer is yes. It does appear that being physically active will reduce the risk of developing diabetes somewhere in about 25 to 35%. And you can see here, these are results from several studies. But again, as we have the number of volume of physical activity increases, that the relative risk of developing type 2 diabetes decreases. And further, if a person has type 2 diabetes, we see that there are, in this meta-analysis and other meta-analyses, we can see that there's a reduction of hemoglobin A1C in aerobic activity, resistance training, where we have many fewer studies. So the benefit is still being understood more fully, and also in combined physical activity, aerobic activity, and resistance training. So very important part of treatment for individuals with diabetes. Being more active does have a beneficial effect in reducing the risk of developing obesity, as you can see here, fairly linear relationship. And we know that individuals who are obese, who engage in physical activity, can have a reduction in particularly in visceral body fat. It appears that there is quite a lot of activity that would be needed, about 3 hours of brisk walking, but that these can result in fairly significant changes in visceral adiposity. And while many who are experts in overweight and weight management might argue that exercise and activity have very modest effects on weight loss, and while that might be true with physical activity on its own over the short term, it's very clear that one is not going to expect to see large weight loss with just starting physical activity, which is disappointing to many people who start exercising. But what I wanted to show here is really a classic study that showed randomized participants into diet only or diet plus physical activity. Both groups got the diet initially, and then the group that got just the diet at first started physical activity after 6 months. And over here, this is the absolute weight change on the left, and we can see the relative weight change over on the right. But what you can see is those individuals who got the exercise along with dietary change right from the beginning had much greater weight loss and maintained that additional weight loss over the 12-month period. And then the percent of change of weight was also greater in that group who got diet and exercise. So this study, as well as others, have really supported the idea that adding exercise along with dietary intervention is a very effective approach to increase weight loss, as well as to maintain weight loss over time. In addition to what is most important for health is to reduce adiposity. I wanted to talk to you also about some of the evidence about exercise and movement on surgical outcomes. So to date, the studies that are available show that they're lower operative mortality and morbidity in individuals who are exercising. Those individuals also have shorter hospital stays, more rapid recoveries, and greater improvements in physical function. And prehabilitation programs, so exercise programs prior to surgery, have been shown to have beneficial effects in reducing the emotional distress associated with undergoing major surgery, improvements of quality of life, as well as to reduce disability during the post-surgical phase. And there's limited evidence right now that individuals who undergo prehabilitation will be more likely to attend a post-surgical rehabilitation program, but there's further work suggesting that that may in fact be a benefit of approaching exercise in this way. So I wanted to show you a few studies here, some data. So here you can see this is the effect of prehabilitation on abdominal surgery, and where these studies have shown that there is a decrease in overall morbidity, and here we can see a decrease also in pulmonary morbidity. This has also been included in some recent guidelines, including these guidelines for recovery after lung surgery. And the statement from these guidelines suggested that prehabilitation is beneficial, but because there's a wide array of types of exercise and content in these prehabilitation programs, that is difficult at this time to make a specific recommendation to how long these programs should last, what's the intensity of activity, the structure, which patients could benefit most from these programs. So this is an area where we will need to continue to conduct further research. And I did also want to mention a little bit about the role of exercise training programs after bariatric surgery, and then several meta-analyses, although not all have found these findings. I thought this was one of the better conducted meta-analyses, and so I'm showing it to you, but these studies have shown that there were greater reduction in body weight, fat loss here as the result of adding exercise following bariatric surgery. There seemed to be no a significant effect on the change in lean body mass with the post-exercise rehabilitation. Further improvements were fairly large improvements in cardiorespiratory fitness or exercise capacity, as well as fairly substantial effects on walking ability or walking distance. Now, we really don't understand very much right now about the optimal type of exercise to realize some of these potential benefits of exercise. This is from a pretty small meta-analysis that did show, of course, that aerobic exercise was beneficial. There are only a couple of studies that have used resistance training, which suggest there may be benefit and potentially some additional benefit of combining aerobic and resistance training. But this is also an area where we need much more work to learn about the optimal approach to exercise, both pre-surgery as well as following surgery. So I'll spend the rest of my talk to talk a little bit about what kind of exercise is recommended and how much you need to do to achieve some of these health benefits, and also how you can potentially counsel your patients about activity. So one thing is that we have a menu of choices for physical activity, which includes aerobic exercise or cardio, resistance exercise, such as weightlifting, flexibility, and neuromotor exercise or functional movement. And I will say that most of our epidemiologic studies have been focusing on aerobic type of activity, and we have much less data on at least the risk profiles of individuals who engage in some of these other activities. But nonetheless, we have evidence that all of these types of exercise have benefits for an individual. And so we can select among these for fit a particular person. And as I showed, there were really no thresholds for benefit for physical activity. And while we know that most benefits are attained at about 150 to 300 minutes per week, which is what is the target recommendation in most of the exercise and physical activity guidelines that are currently available. And we know that there are some health benefits, such as effects on insulin resistance that are immediate. So these are the recommendations. So for aerobic exercise, we're targeting or trying to achieve somewhere between 100 and 300 minutes per week of moderate intensity exercise, such as brisk walking, or about 75 to 150 minutes of more vigorous exercise or some combination. And there are additional benefits in doing more than this. But these are our goals. What is important to know is a lot of people can't do this to start out, or they don't want to. So I always like to emphasize that these are targets, that this isn't necessarily where we're starting to increase our activity, but this is our goal for many people. In addition, doing muscle strengthening activities, so that could be weightlifting, it could be doing things like push-ups and other kinds of body weight exercises, or using stretchy bands or things like that on 2 or 3 days a week are also recommended. And in addition, the neuromotor or functional exercise or multimodal exercise, such as yoga and Tai Chi, but exercise that would include things like balance training and agility, are also particularly important for older individuals, and that recommended probably on 2 days a week. Flexibility exercise, at least 2 days, but more every day is even better. And then the general recommendation is to move more, sit less, and always with the tenets that some activity is better than none, because often we set ourselves up with, well, these are the recommendations. I don't meet the recommendations, so why bother? And the evidence couldn't be clearer that just do something. And if you don't get to do, your run or go to the gym on a particular day, it's not a total failure. So some activity is better than none. And I'll say that, the exercise program is really individualized. So it needs to be individualized for a person's goals, their health status, their responses to exercise, and that may change over a person's lifetime. So we might argue that resistance training is much more important for older adults, and that aerobic activity may be more important in terms of reducing risk of cardiovascular disease or weight management purposes. These are all things that we would want to think about as we're thinking about what's the best exercise for you and what would be the best exercises for your patients. We do also know that if the exercise is pleasant, more likely to do the exercise and keep exercising than if you're engaging in exercise that seems painful or difficult. And although, people respond differently to different kinds of exercises, is something to keep in mind, that we start out with exercise that people find are pleasant or not too difficult to do. They're much more likely to do it. And then you have more opportunity to gradually increase the amount of activity or add different types of activity over time to achieve some of our target recommendations. What works to increase physical activity? I think physical activity and exercise seems very simple, but it's very difficult. It's a complex behavior. You always have to decide to do it. So even those of us who love exercise find that it's not always easy, because we have to overcome that inertia of sitting in our chairs. But some things that have been shown to be powerful are getting guidance from peers or professionals. So for physicians and healthcare professionals, one of the most powerful things you can do is just say to your patient, getting more activity or moving around more would really make a difference for your health. And having support from others, so whether it's family members or friends, can make all the difference of the world. So often, making a pact with a colleague or friend to go for a walk at lunchtime or at another time is really a great method. And technology has really increased our abilities to have ways to help to support and encourage activity, and that can be very effective in some individuals. We also know that there are a number of health behavior techniques that can be helpful in improving exercise adoption and maintenance, and these are health professionals who work in exercise and nutrition we're employing these as we're counseling our patients and clients. So I will always like to put a plug in for trained exercise physiologists and fitness professionals who have studied exercise in a formal way and who have certifications that verify their qualifications. But there is some evidence that working with an exercise physiologist or exercise professional can enhance adherence to exercise as well as safety of exercise, particularly in those individuals who are at higher risk of cardiovascular and other sequelae as a result of exercise. And I wanted to alert you to some potential resources. So Exercise as Medicine is a global initiative that was started initially by the American College of Sports Medicine and the American Medical Association. And its goal is to try to establish physical activity as a standard of healthcare. So its ultimate goal is to institutionalize physical activity assessment and prescription in across global healthcare systems. And the goal approach for Exercise as Medicine is that physical activity would be recorded as a vital sign, and that every healthcare provider would present similar messages regardless of specialty. So patients might hear the message from multiple providers, and also working to try to integrate healthcare into the fitness industry to try to make it possible for a healthcare provider to provide a prescription to a patient who then could go to a local health club or other site, even within the healthcare setting, for filling their exercise prescription. So these are just a few things that healthcare providers can do, assessing physical activity, and there's a physical activity vital sign, and there are other tools where you can quickly assess the patient's physical activity and determine whether they are likely meeting the target recommendations for physical activity. So you have some data on which to assess activity. And then you can provide a prescription for physical activity. There are a number of tools that are available for healthcare providers that can make this process quite easy for you. But essentially, these are recommendations that are consistent not only with the American College of Sports Medicine guidelines, but also with other national guidelines that are pretty consistent across the globe. And then the third part of that is referring your patient to a place where they can fill their prescription. So, and this also may include self-managing physical activity for an person to do independently by giving them some guidance about the type of activity they can do. So trying to find ways that we can integrate community resources with healthcare is one of the approaches from the Exercise as Medicine approach. And just a few things, just as physicians, particularly busy, don't have a lot of time. This may seem like that's not something I'm going to be able to do. It's not a priority for my care for that patient. So I wanted to just give you a few tips that, if you have even just a minute, just giving the message that trying to get 150 minutes of moving, just a little bit of moving in every day would be important to health. You can tie it into a particular health problem, high blood pressure, diabetes, weight, whatever the problem is that the person has come to you for treatment. You may be able to link physical activity and improvements that may occur as a result of increasing activity. If you have a little bit more, you might be able to give a few more messages and actually give an exercise prescription and suggest some useful resources, such as using technology, a pedometer, which are very inexpensive, or Fitbit or Apple Watch, are much more expensive, which can be helpful. And then if you have more time, you can dig more deeply and understand more about that person's interest in activity and the types of activities that they want to do. But I would say even better, refer them to an exercise physiologist who can do all of that for you. But here are some resources that you might find helpful if you're interested. And the Exercises Medicine has Healthcare Provider Action Guide. I have the Physical Activity Vital Sign Assessment, Exercise Prescription forms, and other resources. They also have many patient information forms that are helpful. The Canadians have some wonderful tools in the PAR MedX, which are disease specific, which gives you information about some of the assessments and considerations. And then you can give that to your patient to take to the exercise physiologist or other fitness professional. And I am not sure if this is still going on. I found out when I did my exploration that we do have a number of global centers for exercises medicine. And I found that this, in fact, that in Kuwait, there are some efforts to start a center for exercises medicine. So this may be something to research more. I didn't have the opportunity to check with my colleagues at the American College of Sports Medicine to find out what the status is, but I was pleased to see that Kuwait is part of this global effort, which is present in many, many countries across the globe. So I think we've talked about a lot. We've talked about why exercise is important. So I hope that I've convinced you that it is something that's important for health. I've also mentioned that any movement is helpful. More is better up to a certain extent, but typically we don't have to worry often about people getting too much exercise. And then finally, I have talked about ways you might include physical activity into your care of your patients. So on that note, I will say thank you. Just some greetings from Columbia University, which actually does look fairly empty like this right now due to COVID. But it's really been a pleasure to be with you, and I'd be happy to answer any questions that you might have.
First of all, thank you, Carol, for this brilliant presentation. We actually have some questions in the Q&A panel if you wanted to take them.
Sorry, I couldn't
no problem.
see them.
We thought we'd wait till the end.
Yes, thank you. Okay.
I'll just read them out for you.
That would be great, yeah.
Yeah, so the first question says, to reduce the visceral fat, 3 hours brisk walking is needed. My question is, does it have to be 3 continuous hours, or is it 3 hours total, or 1 hour walking 3 times a day?
Excellent question. It's actually 3 hours total per week. So this walking could be done in very small bouts of time. Most studies would suggest that, even blocks of 5 or 10 minutes so that you're accumulating that amount of activity would be sufficient. I think the expected response might be different for someone who would be morbidly obese compared to somebody who would be overweight. But yeah, it could be done in a variety of ways. So it could be 5 days a week or 6 days a week of shorter duration.
Okay, second question we have here is, how much reduction in HbA1c do you expect with exercise?
I think that the aerobic exercise showed a reduction of a risk by about almost 50% in some studies. I think it's been less than that in some other studies, but it also has some additional, benefits in terms of really affecting the muscle metabolism and glucose uptake in the muscle. So over the long-term, exercise can be quite powerful in that regard.
Okay, our next one, exercise effect on fatty liver disease.
That's a very good question. We don't really have a lot of data on fatty liver disease. I think, if we can, through exercise, can reduce overall adiposity, that may have a benefit. Of course, it depends on the cause of fatty liver disease, but my educated guess is that it would be beneficial, but that remains to be demonstrated more fully.
Perfect, thank you. Next question. Do you recommend fluid replenishment pre, during, or post-exercise?
That's also an important question. I think, it's a good idea to start exercise being hydrated. So, often having water beforehand is a good idea. And especially, I know with your hot weather in Kuwait, Osama and I compare temperatures frequently.
Yeah.
That would be a good idea. And if you're sweating, you do want to replace fluid during exercise. Maybe like a quarter of a glass, every 15 or 20 minutes if it's very hot and you're sweating a lot. For most people, unless you're exercising much longer than 45 minutes to an hour, you don't actually need to use sports drinks and electrolyte replenishment, but cold water is probably the best choice. And then, of course, drinking afterwards is a good idea as well.
Perfect. Can you suggest the best exercise for male or female with type 2 diabetes between the age of 30 to 50?
Well, I would say the best exercise would be a combination of both aerobic exercise and some kind of resistance training, because they do both have effects on muscle and muscle metabolism using some slightly different mechanisms, but exercise can upregulate the GLUT4 transporters. So I would just say, having some combo of those two exercises would be ideal. But if the person's not that interested in exercise, I would say, just any kind of movement. Walking is always a relatively easy activity, but it also could include things like dancing or, anything that would get their heart rate up and that they could potentially sustain for 5 or 10 minutes at a time. One of the things about exercise with glucose management is that the effect is acute and it lasts about 24, possibly up to 20 to 48 hours. So it's really important with someone with diabetes that they exercise. Try for every day, but at least every other day, so that there's consistency, and that will result in kind of the most powerful responses.
Perfect. Our next question. Doctors, I'm guessing physician is saying that they've worked with old patients who do not wish to move an inch. How would you convince senile patients to complete their exercise routine?
Well, that's a challenge. I actually specialize with people who hate exercise. I think often it's just incorporating it by using, games and things that they might do. But, you can even have them, even if they're sitting, there's often different ways you can get them to move at least their upper extremities and upper body. That can be helpful, but it's definitely a challenge. I often equate my work with very young children to that of very old people, that often the same techniques that you use with little kids, which is making things fun and playing games, often work quite well with older people as well. A lot of older people think that they never should move again, especially those who perhaps have worked in more physical occupations. They feel like they've earned a rest and they don't need exercise. So I won't say they need to trick them, but often using different words besides exercise can be helpful.
Do you recommend the 10,000 steps a day or more per week?
10,000 steps is actually a myth. It was developed, the first company that made pedometers in Japan just came up with that number. The amount of steps that are approximately equivalent to reaching the physical activity targets is about 7,500 steps per day. So just so you know that. But 10,000 is even better, and doing more than that is better as well. I think many people find that having steps is a good motivator and keeps them moving. So, certainly that's fine. But if you don't reach 10,000 steps, I know several of my colleagues go crazy at the end of the day if they haven't gotten to their targets. That's what motivates you. That's fine, but it also, don't stress yourself out if you've missed that on a particular day.
Next question. Would pregnant women in the third trimester benefit from moderate exercise, or will it increase their risk of premature labor?
Well, I think most of the guidelines, so I'm familiar mainly with the American College of Obstetrics and Gynecology. Their recommendations are for, moderate activity is fine throughout pregnancy, in an uncomplicated pregnancy. So I think there's no evidence that even doing more vigorous activity is harmful during pregnancy. But the issues by the third trimester, of course, become, change of center of gravity and more challenges to balance and agility. So, at that point, I would just really not recommend, doing activities that are unaccustomed, because there's greater risk of falling and getting injured. But there's no problem in an uncomplicated pregnancy to be active right up to the day of start of labor, and it may be helpful there too.
One other question. What is Professor Garber's favorite form of exercise?
I should have brought a picture. My favorite right now, I do a lot of Pilates, so that, I've changed over the time of my life. I used to run a lot. And as I've gotten older, my various body parts have not enjoyed running so much, but I do Pilates, which has a lot of, muscle strengthening, flexibility, and a lot of challenge. So I really like it, because every day it feels difficult or challenging and has a lot of variety. But I also enjoy riding my cycle, particularly around the city of New York. And when I have time, I am wild about hiking and backpacking.
Very nice. What is your rule of thumb for exercising and watching what you eat?
My personal rule of thumb, well, I try to be active every day. I have to really remind myself every day also of getting away from my computer, because being a professor tends to be a sedentary job with a lot of writing, and especially now with Zoom, that we're not moving around as much. So I try to give myself reminders. As far as eating, I try to focus on having my plate with lots of vegetables and whole grains, no sugar drinks, and just occasionally having a nice dessert. As my dietitian friends have told me, it's fine to do in moderation. So I try not to obsess a lot about what I eat, but I do try to eat a pretty healthy diet.
Perfect. Last question. Do you think using the International Physical Activity Questionnaire is appropriate to use to measure change in physical activity, pre and post a diet and physical activity intervention?
Sure. I think the IPAC questionnaire is a good choice for many settings, and also the fact that it has been translated into many languages, so and validated in those languages, so it does have that advantage. It is, been shown to be sensitive to changes in activity. I think, there's a long form and a short form, and one that's completed and one that's done over either in person or by the phone. So I think depending on what your goals are, you may want to use a longer version or shorter version. In healthcare, in my experience, in my clinical practice, I find that shorter questionnaires tend to work better in patient populations, because you find there's many fewer who actually do any exercise, and they have lots of difficulty answering some of those questions. But I think that is a good one. I also like the GoDen physical activity questionnaire, which is a pretty short questionnaire. I'm not sure if it's, I know it's in French and English, but I'm not sure about other languages. And also some people like the Becky questionnaire, which has some advantages. So it depends on what you want to measure, but I think overall activity, the IPAC can do the job.
Okay, one more. What are some recommended exercises for patients with arrhythmias?
Well, I guess if the question is, presumably they're stable arrhythmia. So, I think they can exercise, engage in aerobic as well as muscle strengthening exercises. Typically, I would say with most cardiac patients, I usually like to start with pretty low levels of aerobic exercise at first, just to see how they respond, whether they have any changes in symptoms, and, ideally monitor them in the first or second session, just to see if the exercise exacerbates those arrhythmias. Often some arrhythmias actually are reduced with activity. And then, if they're tolerating the activity well, then I think adding resistance training, and of course always starting with some warming up, which is particularly important for people who have coronary disease or at risk, so that their circulatory system is going to adapt to the movement. So adding 5 or 10 minutes of very light movement, some stretching can really be a good approach for them.
Perfect. Is it true that resistance training or weightlifting burns calories even after you finish the workout?
Well, not to the extent that many people in the gyms tell you. Weightlifting can result in increased muscle mass, and many people then make the jump that if you increase muscle mass, you will also increase your resting metabolism. And I would say the data are not very convincing in that regard. So even though you may increase your muscle mass somewhat, there isn't a very substantial effect on your resting metabolism. And in fact, you did aerobic activity, the increase in post-exercise metabolism is much longer persisting than with aerobic exercise. But typically the literature is not really supported that there's a big impact on resting metabolism.
Perfect. What exercise recommendations do you have for patients with knee pain or osteoarthritis?
They should move. It seems counterintuitive that having arthritis pain or joint pain would suggest maybe you shouldn't move. And often, people with arthritis don't want to move because of that. But the evidence, and in fact, I took a slide out in my presentation. I'm sorry, I don't have it, which shows, in fact, that exercise, resistance training, and walking or aerobic activity can result in reductions of joint pain. It helps to sort of enhance the lubrication of the joint and maintain the range of motion around the joint. So again, I think for people with arthritis, just doing exercise that's kind of light and moving around is a good place to start, and then adding some resistance training and flexibility would really optimize the approach.
Would you consider aquatherapy or hydrotherapy a good type of exercise?
Absolutely good. Yeah, I mean that often, can reduce increase the ability to move around for people who have limited mobility, and often, the water has some supportive um, effect on the holding up the limbs, and particularly if it's warm, it helps to warm the muscles and joints. So that exercise might be easier. Um, so really, it's a great choice if available.
Perfect. I think we've reached the end of our Q&A for this session. Thank you again, Dr. Garber, for this beautiful lecture. Well, I think we just got one more.
Okay.
Saying, is electrotherapy a good approach?
I think it can help in situations when there is, some immobility, and at least maintaining some of the neuromuscular function. But in terms of really maintaining muscle strength, I don't think the evidence is really that good for that, for doing that. I know some of the recent work with people with spinal cord injury, combining some like electrostimulation along with some movement has been helpful. But I think overall, you still have to move to really get the benefits of exercise.
Thanks again. I think any more questions from anyone, or we can move on. Thank you, Dr. Garber, again for this beautiful lecture. I just want to thank everyone for attending. And I don't know if everyone has seen it, but you can look at the chat. There's a link to register for our next session. Our next session will be the same time next week on Sunday, the 15th of November at 8 p.m. It will be with Dr. Thomas Brownlee and Vicente Beltran, and they're going to look at the various ways you can exercise. So they're going to delve deeper into the strength and conditioning, triathlon training, and all these different exercises and how to tackle them and be part of it. The QR code you see on the screen, if you can just take your phone camera and just take a picture, it will automatically take you to the registration for next week's lecture. Again, thank you to everyone that attended, and special thank you to Dr. Carol Garber and the Surge Kuwait team who have been very helpful with this lecture series, and I hope to see everyone next week. And again, sorry about the technical difficulties at the beginning. Thank you.